Dear colleagues, this is an intumescent cataract. We have started the case. The main incision is being given at this time. After the main incision was given, aqueous humor came out and the intraocular pressure became less, so I inject air through the main incision, and now I inject trypan blue dye to stain the anterior capsule of the cataract. Here it is. I stain the anterior capsule always beneath an air bubble. Now the dye is washed out within 4 or 5 seconds. Whatever staining occurs within 4 or 5 seconds is enough to do capsulorhexis. Viscoelastic substance 2% hydroxypropyl methyl cellulose is injected now. I do not use any cohesive viscoelastic substance in intumescent cataracts. One side port is made on the right side of the main incision and another one is made on the left side of the main incision, about 2.5 clock hours away. The main incision in this case is 2.8 millimeter. Now the capsule is incised with a 26 case bent cystitome. The flap is raised and we can see that milky fluid and oily fluid, mixed fluid coming out through this punctured site. Now a small rhexis is attempted through this. I thought it is done. Now as I wash, I can see that the minirhexis is not complete, and when the minirhexis is not complete, we should not handle it much. I inject visco again, hold this tag with utreta and complete the minirhexis. This is very important because if the minirhexis is not complete and if we are going to introduce any instrument, Simcoe or bimanual IA, whatever it is, through this small incision, a small minirhexis, the rhexis can extend to the periphery. But if it is a complete rhexis, it will resist the force being applied on it. Now a small cut is made at the margin of the rhexis, minirhexis. Ureter forceps is taken and an optimum sized rhexis is done. I insist on using this instrument, ureter forceps. It is so useful. Those of us who are using needle for capsulorhexis must practice with ureter also, because you never know when it will be necessary, and if you are used to it, it will be easy when it is required. Now this is Oatley's phaco machine, Oatley's Cataracts 3 phaco machine. I embed the phaco tip and make this chop. This is direct chop. You can see that this air bubble is not moving even with while I am chopping. So the fluid current is not enough to give some the air bubble has gone now. At this time the phaco power is, in this case, 60%, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. This is the last portion of the nucleus, and while I remove the last piece, I remove the chopper so that the posterior capsule goes behind towards the vitreous cavity, and I can confidently emulsify the last piece with the same 450 vacuum. But I will recommend for the beginners to decrease the parameters, make the vacuum about 100 or whatever it is you are comfortable with, and then emulsify the last piece. Now I take a Simcoe cannula and clean the cortical matter. Whatever instrument you are comfortable with, you must use that, but thorough cleaning of cortical matter is necessary. There should not be any lens matter left. If some lens matter is left, it can give rise to lens particle glaucoma, or we may have to use steroids frequently, and if the patient is a steroid responder, then we have to face another challenge. So thorough cleaning of this cortical matter is necessary. After this, in this case, I am injecting viscoelastic substance, HPMC again, for implantation of the intraocular lens. The chopper guides the trailing haptic into the capsular bag. This haptic is sticking to the optic. It is released and it also goes into the capsular bag. The lens is dialed and the haptics are placed at a desired meridian. That's it. Now we have to remove the viscoelastic substance thoroughly. Unless we remove this viscoelastic substance thoroughly, there will be a rise of intraocular pressure. The patient may have pain in the night. The patient may not be able to sleep well. The patient may have lot of discomfort. So we must remove all the viscoelastic substance. I remove it first with Simcoe, then again with bimanual IA, so that it is thoroughly cleaned. You can see that the rhexis is almost circular in this case. Now the side ports are hydrated, antechamber is formed, and the case gets over. Hope this video will be useful in your practice. This is the final wash under higher magnification. Thank you very much for your attention. Thank you again.